second pillar is find or create space. Teeth move easily with space. If you notice ads for Smile Direct or any other type of aligner system on the market that's being presented to consumers, oftentimes they are showing teeth with spaces, with diastema, or the teeth are flared forward and there's large spaces in between the teeth. Those are the easiest teeth to correct. When there are no impediments to the tooth movement, the aligners work excellently. So either you have to find patients with space or you have to go ahead and create space for that patient. Space can be our friend. This patient, it bothered him. He was edge-to-edge occlusion. His diastema did not bother him. He had it for years. This fellow's in his 50s. But what I saw was happening was he was destroying the incisal edges of his maxillary and mandibular teeth. Once I point that out to him and I show him that he's grinding his anterior teeth, which were not meant to grind, which were meant to incise, then that is how this patient accepted orthodontic treatment. That being said, he got into this and he loves his smile. So once there are spaces in between the teeth, these cases are very, very easy to do. If you don't have spaces in between the teeth, you need to somehow create space. There are two ways to create space. One is arch expansion. As you move the teeth outwards and they move into a greater circumference of a circle, then more space develops in between them. But sometimes you can't, or it's insufficient to expand the arch. There's just not enough room. You'll move the teeth off the alveolar bone. So somehow you have to either remove a tooth or have to do something called IPR, interproximal reduction. You can do interproximal reduction with a high speed. You can do it with some type of abrasive strips. I found that in the bicuspid area, because the teeth are very thick, it is much more efficient to do it with a very tiny high-speed diamond, create space in between the teeth. When you come to the anterior, this particular product from Dentsply Sirona called Space File allows you to get in between the teeth. They sell a handpiece. It's a reciprocating handpiece, which kind of works the saw backwards and forwards. These devices you can use in your own hand, or you can go ahead and put them into the handpiece. What I typically do with this case, with these types of cases, is I start with the finest, the finest interproximal refinement tool that I can. And once I work that in there, I start to go to some of the medium and coarse sizes. Once you get to those sizes, because if you try to place the coarse space file in between the teeth, you can't get it in between there. So by starting with the smaller ones, the thinner ones, you're able to create a little bit of space in there, and then you make the spaces larger and larger until you create the space that you need. If you take off a 0.5 millimeter off one tooth on both the mesial and distal, you now essentially have created 1 millimeter space, 1/2 on each side. If you do that over 5 teeth, you've now created the space of a lower incisor. So 0.5 millimeter, mesial and distal, across 5 teeth, it's like you took out a tooth. And this is how to create space and make room for movement, because once the teeth jam into each other, once they bump up into each other, the aligner therapy or any therapy is not going to work. The teeth can't move. They're locked in. So in a case such as the one on the left side of your screen is much different than the case on the right side. The case on the left side is an easy case. You can close those spaces very easily. You typically have to retract the lower anteriors, and this is another good point to mention. We talk about doing, and patients talk about doing, single arch therapy. Many times in single arch therapy, it's inappropriate because as you're moving teeth, they start bumping into the opposing arch. So most of the time, my cases involve doing both arches. The case on the right side is much more complex. You have to create space there. You can use aligner therapy as a pre-prosthetic case. This patient, if you look at the slide on the right, is pretty much crowded out totally, to the extent that she has one tooth that's mobile, and we're going to be taking out actually number 24. We're going to take out number 24 and move things around. I tell the patient, if I can't get the space closed, then at that point, we're going to do veneers, we're going to do composite bonding, we'll do crowns to bring it together. This is a tool that you as a general dentist have that an orthodontist doesn't have. You can go ahead and do finishing improvements, because usually at the end of the therapy, the patient is done. And when I show patients, I can put you into some more aligners, or I can close the space with some composite bonding. Most of the patients, once they see how it looks, opt to do the bonding or the veneers. In this particular case, she knows from the get-go, excuse me, especially with the uneven incisal edges, that we're going to be doing some type of restorative therapy at the end. So even when we're doing the orthodontics in this particular case, we're following it up with restorative dentistry, which now makes this a very, very nice case. This is the CLEARaline software. And the CLEARaline software, which, as BJ mentioned earlier, is the product that Roe is offering and helping their doctors with. It has a very intuitive user interface. You can see here, as you go from the top of the screen to the bottom of the screen, the movement of the lower incisors as we are correcting a midline discrepancy, and we're also correcting some crowding. It's crucial to be able to see this ahead of time. Before this was around, we used to do analog therapy, and analog therapy was way back when in the early 2000s, where a lab would go ahead and cut teeth off a model, reset them, and then along the way do various Essex style retainers. And that is how the aligner therapy first got started. Now that we've moved to scans and digital, it's much, much different. As a side note over here, we're talking about Essex retainers. The term Essex is an acronym for S6. And this was a Dr. John Sheridan who devised the Essex retainer, and he called it Sheridan's Simple System for Stabilizing the Social Six. That's S6. 6 S's there. That's a little bit of trivia into the name Essex retainer. So we spoke about identifying your patient. We spoke about creating space. What's the sweet spot? What sells cases? There's certain numbers in an office, and you'll learn your own demographics, excuse me, where you go above that, a patient is not going to touch the case. So I have found in orthodontic therapy that if you're somewhere between $1,500 to $2,500, that is a manageable number for an overwhelming majority of patients. It's something that can be paid off over time. It's something you can do throughout treatment. You can make 3 easy payments, 4 easy payments, 6 easy payments. You can finance it with any type of third-party marketing. Length of time, 3 to 6 months is good. When you tell a patient they need orthodontic therapy and they find out they're not going to be treated for 1.5 years or a year even, and you tell them we're going to get you done in 3 to 6 months, and again, this is patient selection, they go with that. And the last thing is retainers. Retainers are always an extra fee. And the reason the retainers are an extra fee, because we never know where the patient is going to go with their retainers. So whatever your case is going to be, we go ahead and apply the retainers at the very end, and it becomes an ongoing maintenance, because I tell the patients that you need to get your retainers probably replaced once a year for 2 reasons. One, they usually aren't the most hygienic looking devices at the end of a year. That's number one. Number two, you want to have fresh plastics. Retainers are meant to retain, and the only way they retain if the plastic does not spring. So we have typically a yearly program and a fee built into our cases that we tell them that once a year, we'll be going ahead and replacing their retainers. Records has to be the same approach every single visit, every single new patient, excuse me. You need to do photographs, you need to do scans. If for some reason you don't have a scanner, then you can do a PVS impression. But you need to have good mirrors, you need to document these cases. It's very important that you have before and after. First of all, you create your own library of before and after that you can show to other patients. But second of all, if something goes awry, you showed what they look like before and where they're looking afterwards. And this is very, very important. Patients don't realize how much of a change happens in a short period of time. The ability to document is crucial. When you do photos, your photos should consist of an anterior shot with the teeth together, a right buccal, a left buccal with the teeth together, and then those same 3 shots with the teeth apart. This is crucial because if you want to document crooked lower anteriors, as we keep on mentioning in this webinar, you need to have the teeth apart. So you've done 6 pictures like that. Then you need a maxillary occlusal, a mandibular occlusal, a smile, and a wide smile. And the wide smile is important to line up the midline, especially if you're doing a correction, and often to tell the patients that their midline is off at the original diagnostic visit. And the last part of ortho-aligner success is consent forms. Patients have to understand the scope of treatment. When we talk to a patient, when I talk to a patient about what we're trying to accomplish, we establish goals. The goals are, we are going to unravel your lower anterior teeth. We're going to close the space. If you don't define the goals and convey it to the patient and then note it in the patient's records, then you'll never know when you're done. Because the patient may say to you, well, this one's like this and that one's like that. Mrs. Smith, that wasn't part of our original treatment. Oh, yes, it was. No, it really wasn't. So this is something that's very, very important to define your goals so you know when you are done. If the patient decides to stop in the middle of treatment, you have to define their abilities, their responsibility, your responsibility, their financial responsibility, and your financial responsibility. And you could call it any way you want depending on the patient. Of course, you've made the aligners, you paid for them, you started the treatment, they stop in between. Do you charge them a full fee? You very well can, because you've done everything you're supposed to do. They just haven't complied. Or do you not? Because you want to retain the patient, or you're doing a big case on their husband or wife or significant other. That's kind of your call. But if you define it all at the beginning, there's no chance for making mistakes. Now, every orthodontic consent form has in there the possibility of causing a tooth to need endodontic therapy or fractures. Once you move a tooth into a position, their bite can get off at that particular point, and you need to address that. I've never really seen it happen. The bite can go off, that's for sure. And that you either correct with an occlusal equilibration or put them into more aligners. So it's really important to get your consent forms up to speed so you know exactly where you're going and the patient knows where you're going also, where both of you are going.